Well, good afternoon, everyone, and welcome into another one of our WXYZ web chats featuring the healthcare professionals from St. Providence Health System. I'm Warren Pierce, and for the next hour or so, we're going to be zeroing in on stroke. Now, the last statistics I saw suggested that every year almost 800,000 people in this country have a stroke. What is it? Are you or someone you know at risk, and what causes it, and what are the signs or symptoms that you need to be aware of? Joining us in our web chat studio this afternoon, this Tuesday afternoon, from the St. John Providence Health System, a couple of experts on the subject. Dr. Richard Fessler, specializing primary neurological surgery. Nice to have you with us, Doctor. And Dr. Bruce Silverman, who's the lead neurologist in the Neuro On-Call Stroke Network. Doctors, welcome. And I suppose we should start from the beginning and expand from there. And we'll remind our viewers, they're on the web already. They can email us a question for you. They can call directly at 248-356-0077. But Dr. Fessler, let me start with you. What is a stroke?
Well, simply, it is a lack of blood flow to the brain that causes it to die.
Causes what to die?
It will cause your brain to die. And the most common kinds of stroke are hemorrhagic strokes and ischemic strokes. A hemorrhage is when, of course, you get a blood clot in your brain. And an ischemic stroke is when a blood vessel gets a blood clot in it and blood can no longer pass through.
And so we're talking here, Dr. Silverman, about the cells that begin to die in the brain?
That's correct. I mean, the brain is a very unforgiving organ. And when it is starved oxygen through the lack of blood supply to a particular region of the brain, neuronal cells begin to die very quickly. And that's the reason why the adage from the American Heart Association, which is time lost equals brain lost, is so important. Because recognizing a stroke is paramount to the success of treatment. So these neurons are dying very quickly as the blood is not making it to that region of the brain.
And we've got to talk, too, about some of the symptoms as well, Dr. Fessler. By the time, you see a patient, it may be, 2, 3, or 4 hours since the symptoms began to unfold?
We hope it's faster because I think, as Dr. Silverman alluded to, time is brain. And we ask people to remember the acronym FAST for face, arm, speech, and time. People who have a stroke frequently have weakness of their face. That usually is associated with trouble with their arm, and they have difficulty with speech. And time is critically important. The sooner the better.
What about trouble seeing? Could that be another symptom as well beginning to unfold with the stroke?
Oh, absolutely. And the reality of the situation, while Dr. Fessler articulated very clearly this adage of the fast phenomena, you really have to be in tune to many different symptoms that can be associated with stroke. People can have headaches. People can complain of dizziness. They complain of visual loss in concomitance with the other symptoms that were described. So, when there's a change in you from a neurologic perspective, you really need to look back at your history and try to define what's going on, especially patients who may be suffering from hypertension or diabetes. Being aware of these changes in you could alert you to the fact that you might be having a stroke.
Why is it called, and I don't know if you ever get this or not, Dr. Fessler, why is it called a stroke?
That's a good question. I'm not sure I know. But we're now beginning to call it a brain attack, actually, much like a heart attack, so that people are aware that this is an emergency. Because in the past, people often had their stroke and would stay home and go to bed. I remember 10 or 15 years ago, patients who had their stroke in the morning, thought it would go away, went to bed. And in the last 10 years, we've really had a tremendous emphasis on public education. And the terminology has begun to change a little bit. And we now talk more about brain attacks because those are treatable events.
And this attack on the brain, Dr. Silverman, with the oxygen not getting to certain areas of the brain, killing the cells instantly?
Instantly.
Are there no backup cells?
Well,
Is there no redundancy in our body like that?
there is. The fact of the matter is that while we can't rely on it, there is the phenomena of what we call collateral circulation. And collateral circulation is such that if you have an area or a blood vessel that becomes blocked, what happens over time as it becomes narrowed is blood flow from other regions in the brain come in to help feed that region of the brain that is not getting enough blood supply. And so collateral circulation is one of the ways the brain can overcome some of the illness that it is experiencing at the time. I just want to reflect back to something that Dr.
Sure.
Fessler, the question you asked him about, why the term stroke. And I would agree that the idea of a brain attack is really on the forefront of our minds so that people can take their symptoms very, very seriously. When they've got a change in them, they become alerted to it and they don't try to wait it out. Because the type of therapies that we can provide, Dr. Fessler and myself, are very time-locked. So it's extremely important that when you begin the symptoms, that you act immediately and call 911. You don't call your general doctor. You don't call your Aunt Hilda to ask her what's going on, but you activate an emergency services system that can get you to the nearest institution so that the initiation of treatment can occur. But back in the old days, when we used to talk about stroke, stroke could be a symptom of many different brain lesions. Like, for instance, a brain tumor back in the day could have been considered a stroke prior to the day of imaging, CAT scan and MRI imaging. So stroke is a more global term, for me at least, as to the clinical symptoms. And the idea of a brain attack, with the new imaging that we now have available, we can define exactly what that stroke is, be it a brain tumor, be it a stroke, like an ischemic stroke or hemorrhagic stroke where there isn't enough blood flow going to a particular region of the brain. So it's almost like an automobile and a Chevrolet and a Ford and a Chrysler. You have the major diagnosis, and then there's multiple reasons why that can occur.
All right, but Dr. Fessler, so there is this lack of fresh oxygen getting to the brain, and you explained there are a couple of different types of strokes that are occurring, and we'll get to that. But is it kind of instantaneous? Could it be building? Could it have been building for a few hours or a few days or a few weeks before these symptoms make themselves known to either the individual or someone who knows what's happening and is observing and saying, hey, this, as you call the acronym FAST, you're experiencing some symptoms here of a stroke. We have to call 911 and get you to the hospital. How long has this been going on to bring on these symptoms?
The build up to the stroke is your entire life. The way you live, the things you eat, who you are, your genetics. However, there are some things that you should be aware of. For example, something we call a bruit, which is a noise that a physician can hear when they listen to your neck from a narrowed blood vessel. So the blood vessel gets so narrow that you can literally hear the blood whooshing by. That's a sign that you may be at risk sometime in the near future for a stroke. Some of the other symptoms that people are aware of are what we call transient ischemic attacks. So you get a mini stroke that goes away. So suddenly you forget what you were going to say. You're in the middle of a sentence and you stop. Or suddenly you have trouble reading something that you've read all the time and then it gets better. Weakness or numbness in an arm or leg. And a TIA can be a warning sign of a stroke that's going to happen.
All right, we mentioned that you're online at WXYZ.com. Feel free to email our doctors any question you have. This is something that's very important, not only for you as an individual, but to be aware of the symptoms too and to be able to help others, whether it be colleagues or family members, something like that. Phone calls, feel free to dial us at 248-356-0077. Michelle is calling in with a question for the doctors. Are strokes hereditary, and is there such a thing as small strokes? Well, you mentioned mini strokes a little while ago, and would you know that you're having one? So I'll pose that to the both of you. Dr. Silverman, let's start with you.
Okay. Well, to start out, certainly there are people that have a tendency towards strokes, and there is a familial event that can occur within families where people's blood will clot more than what that should occur. And these people are considered hypercoagulable, meaning their blood clumps more than what you would expect to see. And so individuals that are hypercoagulable and have greater amount of clumping of their blood are at greater risk for having stroke.
And that's hereditary.
And that can be a hereditary phenomenon.
Right.
So there indeed can be that occurring as far as hereditary is concerned. But that's a minority of strokes. It can occur, but it's a minority of strokes. And to answer the second question, is there something such as a small stroke? And for me at least, when I first started to learn about strokes, strokes can occur in small vessels, which we call a lacunar stroke, or it can occur in a large vessel, and it can take out a large lobe of the brain. And a lacunar stroke is a small stroke less than 1 centimeter in size, and it's related to the blood flow that comes from an arteriole, and that's why we call it arteriolar sclerosis, or hardening of the arteries. And so when these small strokes occur, the brain is a very large organ and have lots of silent areas. So there are small strokes that can occur in a silent area, but there is a small stroke that can occur in a very important area. An area like the internal capsule that carries our motor fibers down so we can move our arm, or in areas that can leave us with tremendous amount of weakness. So you can have a small stroke that can be very silent, and you can have a small stroke that can be very profound. And you really can only define that based on the location of where that stroke occurs.
And certainly, Dr. Fessler, we hear about, and we'll talk about ways to prevent this from happening, lifestyle changes, for example. But we talk a lot about cholesterol, the plaque buildup in arteries, leading to a heart attack, leading to a stroke. If you could briefly explain, and then we'll get to some more incoming emails as well at WXYZ.com. Plaque is building up in an artery, and then apparently it can break off and then travel up toward the brain?
It can. So we all hear about hardening of the arteries. Hardening of the arteries is really the sum total of all the things we do to ourselves over the course of our lifetime. And our arteries they have 3 layers. There's a very smooth inner layer that allows your blood to not stick to the blood vessel.
Right.
The next layer is muscle, and it's what allows your artery to expand and contract as your heart beats. And then there's a very tough outer layer. That cholesterol and fat begins to build up in that middle layer. And it can build up so much that it begins to extend into that inner layer. And occasionally it ruptures or breaks off. And so not only can those small pieces that break free cause trouble downstream, but that area of the artery that's now exposed can cause a blood clot to form. And that's how heart attacks often occur. So in our hearts, the same as in our heads and our necks and other places, these diseased arteries can let loose this fat and cholesterol and calcium that's built up over the years. And not only does that piece that broke free cause trouble downstream, but the area where it broke loose begins to form a blood clot because your body thinks that that's an injury.
So the arteries can be clogged, or in the brain there could be a bleeding that takes place as well, and we'll talk about that area as well. But we're looking for your incoming emails too at WXYZ.com. Just tuning in, we are talking about strokes on this Tuesday afternoon. More than 250,000 happen each and every year. So it's WXYZ.com, the email to our 2 doctors here specializing in strokes, or phone calls 248-356-0077. Nancy emailing us recently had floaters and flashers, and I know what those are, probably occurring in one of my eyes right now, in the left eye, same side of her stroke. Are these considered mini strokes, and are they related to the original TIA? And the TIA stands for?
Transient ischemic attack.
So does it have anything to do with a mini stroke when she sees these things floating in your eyes?
Well, in reality, Warren, there are floaters.
Right.
And every time
I got one right now. I can find it here in a second.
Maybe it's just dust. I don't know.
Yeah, right.
But there are floaters, and so every time you have a floater or a flasher in your eye, you can't assume that is a warning of a stroke. But it's so happens.
What about if you've already, as she has, had a stroke, though?
That's a very valid point. And so there is a phenomena that can occur called amaurosis fugax.
We got a lot of big words when we're talking
Neurologists
about
and
strokes.
neurosurgeons tend to use big words.
Yeah.
I say anyway.
We need more acronyms,
yeah,
but go ahead.
But amaurosis fugax is a situation where one of the carotid arteries that Dr. Fessler was describing may actually develop some degree of narrowing, and as that narrowing occurs, it causes a disruption of the normal flow through that blood vessel. And just as Dr. Fessler mentioned, the body sees that abnormal flow as being irregular and ultimately leads to the development of small clots. And as those small clots tend to break off and go north towards the brain, the first artery that comes off of the internal carotid artery as it enters into the skull is called the ophthalmic artery. And that ophthalmic artery, if a small clot finds its way in there, can cause a more classic visual event of a shade closing in front of your eye. Now, some people describe it as a floater, some people describe it as a flasher, but we as neurosciences people, when we hear that phenomena that a shade is closing, that kind of raises our level of awareness or concern about the possibility of a TIA. So I would suggest to this caller, Nancy, that if indeed you are finding that you are having some visual events within the territory or the blood supply from that artery, it would behoove you to get a diagnostic procedure done to look at the blood flow, like a carotid ultrasound, to see whether or not there is indeed a blockage occurring in that vessel.
And Dr. Fessler, she's also concerned because she had a stroke already about having another stroke, but she says, they're difficult to anticipate. Are there any suggestions of earlier signs?
Well, the best thing to do is to see your primary care physician regularly.
Right.
Because they will work with Nancy to minimize what we call risk factors, right? So everyone, unfortunately, once you've had one stroke, you are at increased risk to have another. And so what we like to do is we like to say, okay, we need to work on diet, exercise, blood pressure, cholesterol. We want to work
Smoking.
Smoking,
Let's
absolutely.
throw that one in there too.
Absolutely. And we want to make sure that we're doing everything we can to lower every individual's risk.
Right. And doesn't smoking, I'm so anti-smoking here, Dr. Silverman, but doesn't smoking also begin to cut off the oxygen too? We're talking about blood clots, but smoking is cutting down the oxygen flow too to places like the brain, I would assume.
Absolutely. I mean, the smoke, the carbon monoxide from smoke, binds to the hemoglobin and doesn't allow oxygen to bind. So it takes up the receptor sites on the red blood cells so that oxygen cannot get to the region of the heart, the brain, the kidney, whatever it is. And smoking is a huge, huge issue in regards to stroke. In fact, there's a statistic that I read that showed that if you stop smoking, within 1 year, you can lower your relative risk of having a stroke by 50%. And at the end of 5 years, you can lower your relative risk of having a stroke back to baseline. And that's a huge statistic because of all the things that we do in the face of an acute stroke, the reality is what we do is minimal as compared to what your viewers and your listeners can do to help them prevent themselves from having a stroke.
Even we could throw in secondhand smoke as well, not being a smoker, but in an environment where there is smoke causing, again, the oxygen not to flow as freely as it should because of this secondhand smoke as well.
Absolutely, absolutely.
All right, another incoming email, and you can email us right now as we talk with Dr. Fessler and Dr. Silverman, both in talking about strokes here on this Tuesday afternoon. We've got one from Nikki. She was taken to the nearest hospital, symptoms unable to express herself, had poor balance, had a heart block on the monitor, and she was glad for the fire department around the corner, which was terrific. Still has periods of poor expression, losing balance. Healthcare primary won't return the calls. That might be another issue. But where does she start to get a new one? And what about those symptoms after she went to the hospital? Dr. Fessler, what do you think?
Well, it sounds as though Nikki had a stroke. And
Although she doesn't really say that here, whether it was diagnosed as a
Right.
stroke.
but some of the difficulties with balance and difficulty with expression, that certainly sounds as though that might have been related to a small stroke. Sometimes heart trouble is related to having these strokes. What I would recommend is that we really do need to get her some regular help from a primary care physician and perhaps a neurologist. And I'd recommend that she can start with, not to give a plug, but start with our website, the St. John Providence Health System website, and she can find a new physician there.
And Nikki mentioned a small stroke, Dr. Silverman, and we earlier just touched on the two main types of stroke. The ischemic,
Ischemic,
that's one, and the hemorrhagic.
hemorrhagic.
All right. And the ischemic, what occurs if an artery that supplies this oxygen-rich blood to the brain becomes blocked? Then what begins to unfold, and how is that become blocked?
You know, I want to take one step backwards.
Go ahead.
I think this is a really important point that you've brought out, and so has Richard. And Nikki actually brought it out as well. And Nancy, there is no such thing as a small stroke.
Right.
You know, your brain, as I mentioned at the very beginning, is a very unforgiving organ. And it does not recover very well to insults. And it's very, very important that we take really good care of our brains. And it's really, really important that we take a close look at ourselves and look at our risk factors and try to manage them as aggressively as possible. I think if we look at the most recent literature that's been released in the neurology and neurosurgery venues, we know that managing risk factors is the single most important thing to preventing secondary strokes and preventing primary strokes from occurring. And the idea that there's such a thing as a mini stroke, to me, rubs me the wrong way, because it gives people a little bit of leeway to, well, I'm only a little weak in my right arm.
Yeah, right.
You know, I mean, you really have to look at, I try to raise the issue to my patients that the mini stroke it's a warning from God. You better this should be your wake-up call.
If there has been a mini stroke, have there been cells that have been killed?
Gone.
Gone.
Dead. Never to be gotten again.
And let's go to our phone lines now too, and take a call from Rachel. Is that you on the line? Let me see if I can hear her. Where is my little earpiece, Seth? I think we should have Rachel on the line. If I can.
Yeah.
There you go. Rachel, is that you? Rachel.
Can you hear me?
Yeah. Can you hear me?
Yes, I can.
Good, Rachel. We've got Doctors Fessler and Silverman here, wondering about your question concerning stroke today.
Yeah, my dad passed away from stroke a few years ago, and I was wondering if I'm in high risk, especially my cholesterol is very high, triglyceride is high, and my HDL is low.
How's your blood pressure?
Blood pressure is fine. It's always below normal.
So we're talking here about a family, Dr. Fessler, and if in fact her dad died of a stroke, then what are the chances of increasing the chances of a stroke in her?
You know, Rachel, I don't think that necessarily means that you will have a stroke. You know, I think it's important to realize that sometimes we don't realize that something happens to all of us at some point. And stroke in our country is the fourth leading cause of people dying. And once you turn 55, and I know Dr. Silverman must be there, but once you turn 55, your risk of having a stroke doubles. And it actually doubles every 10 years after that. And so as each of us gets older, our risk goes up no matter what we do, and it's really a matter of trying to manage those things that we can. And as Dr. Silverman said earlier, you know, as long as you don't have a genetic or an inherited predisposition, which your family physician could help you figure out, it's really a matter of working on those things like your triglycerides and your cholesterol, which you just asked about. You know, it's important that you're eating right and that you perhaps may need to be on a medication to help keep that down.
All right. Thanks for calling in, Rachel. We appreciate. Go
Can I
ahead.
ask one more question?
Sure. Go ahead, Rachel.
If you can't take statins because of cramps in the legs, is there something else I could do?
You know, there's multiple things that you can do to lower your cholesterol, one being diet, the other being exercise. So not everything and not every problem that we have is fixed by a pill. I think that the most important thing that if you are suffering from high cholesterol and high triglycerides is to reach back to your primary care physician for a well-coordinated medical program to manage that particular risk factor. But I have to applaud you, Rachel, for asking these questions because unfortunately your father had his demise with a stroke. But it sounds to me like you're mindful of this and trying to do something to help protect yourself from getting that. And the most important thing is not only to yourself, but to try to get the word out to your community. As you probably know, the month of May is National Stroke Month, and so we're trying to get the word out to the community to be mindful of the risk factors of stroke and the symptoms of stroke so that we can limit the amount of mortality and morbidity related to this disease.
And we've got the doctors here from St. John
Thank you.
Providence working with us to make sure we spread the word about what the symptoms might be, the two main types of strokes. We talked a bit, Dr. Fessler, about this ischemic, and then the other one is the hemorrhagic. I believe I'm getting these names eventually. By the time we get to 6 here, I might have them down. But this second one is the one where a clot moves up into the brain area?
The hemorrhagic stroke?
Yes, yeah.
A hemorrhagic stroke is actually from a blood vessel that bursts. And all of our blood vessels branch in a very particular pattern, just like tree branches. So they go from larger to smaller. And sometimes the smaller ones, particularly in people who have high blood pressure or poorly controlled blood pressure, they may actually give out from the pressure and bleed. And that's a hemorrhagic stroke. And then there's a much less common type of hemorrhagic stroke that's caused by the rupture of an aneurysm, which is a little bit different issue.
We've got another incoming question on our WXYZ.com website, and feel free to send us an email to our doctors here, and a phone caller as well. Let's. I believe we have no call, but we do have an email coming in from Hassan. Can rheumatic fever lead to stroke? The atrial fibrillation, is that what it is, Dr. Silverman?
Yes. Atrial fibrillation is a condition that is within the heart and causes an irregular cardiac rhythm to occur. And when this irregular cardiac rhythm occurs, it can cause the various chambers of the heart, specifically the left atrium, to enlarge. And just like the carotid artery, when blood is not flowing through vessels or chambers in a very organized manner, it can cause turbulent flow to occur. And when there's irregular and turbulent flow, this can lead to the formation of a clot. And so when a clot occurs within the heart, it can break off in the face of an atrial fibrillation and cause a stroke to occur. And rheumatic fever can lead to the irregularity of atrial fibrillation, which can ultimately lead to a stroke.
Well, that's your answer. Thanks for the email. Feel free to call our doctors here or email us as well at WXYZ.com. Another, I believe it's VT, we'll use the initials there, wondering how to identify a stroke. it's about to happen? Is there a feeling? Is there a sensation? We talked about, and keep in mind too, we have a lot of new folks tuning in and tuning out too, so we'll kind of recap and bring you up to date on this month of May being Stroke Month and try to keep you on top of that. But can there, Dr. Fessler, be a slow buildup and all of a sudden then the symptoms, you could be drooling, I suppose, your speech would be impaired, you mentioned that too, wondering how to identify a stroke that's about to happen. And what does a stroke about to happen mean?
Unfortunately, sometimes strokes are a lot like heart attacks. You're fine until it occurs. And I'll go to the second part of the question, which is there a feeling or sensation in the brain? Our brain actually doesn't have pain sensation. And so injuries to the brain really aren't felt.
What about headache?
Well, headaches a little bit different and usually caused by irritation of nerves and muscle tension. Now, our blood vessels in the brain actually do have pain fibers. And so blood vessels can hurt, and frequently when a blood vessel ruptures or an aneurysm ruptures, that hurts, and that's felt as pain, and the lining of the brain is innervated, and so we feel that. Going back to stroke, though, we talked earlier about our acronym FAST. People who have
why
a stroke...
don't you give out the meaning of that acronym as well?
People have an abnormality of their face, difficulty with perhaps an arm on the same side as their facial weakness, difficulty with speech. And of course the T stands for time. Time is incredibly important. You need to get to an emergency room as quickly as possible.
By the time you possibly see that patient, it's pretty much, 3 hours has unfolded since the symptoms began, or is there's a concern that a stroke is taking place?
We hope it's not 3 hours.
No?
We hope it's within an hour, because many of our treatments are time limited. And the medication that we give to dissolve blood clots in the brain, we really need to give that within 3 hours.
That could be happening in the ambulance because you've called 911 when you've recognized these symptoms, and they're helping out, Dr. Silverman, in that vehicle going to the hospital?
Well, in reality, there's some measures that need to occur before one can provide certain services in the face of stroke. So yes, when you activate the emergency services through 911, which is what we would promote that you do, rather than getting in your own car and driving to the hospital or calling your neighbor and asking them to drive you, we really feel that the most important thing is getting to the hospital, getting to a medical facility for immediate care. Warren, I think you make a good point that there can be some things that are done urgently in transport. One thing that we want to do is we want to check vital signs on these patients. So if somebody's blood pressure is really high, we can kind of gently evaluate that and perhaps initiate some therapy. The EMS team may start an IV. The EMS team may be put them on oxygen.
Well, what about blood thinners?
Well, the problem is as you've articulated kind of well, ischemic versus hemorrhagic, one of the most important measures within the diagnosis of stroke is it a bleeding stroke or is it a lack of blood supply stroke? Because if you give a bleeding stroke a blood thinner, you can promote further bleeding. So what you need to do is get to an institution that has a very coordinated attack towards management of stroke. And that's kind of like leads into some of the things that we're doing with our stroke network, because we're reaching out to institutions that may not have neurosciences backing and through remote presence able to care for individuals that may not be able to get the care that we're able to provide within our St. John Providence healthcare system.
What about, and we'll get to another email, or don't forget you're at WXYZ.com, so feel free to email us or call directly to our doctors here in the studio this afternoon, Dr. Richard Fessler, Dr. Bruce Silverman. They're both here on this month where we try to find out as much as we can about strokes. There are close to 900,000 cases each and every year here in the United States. So feel free to email us or call us at and then 3560077. What, Dr. Richard Fessler, about aspirins? Is that a good preventative that we hear about? Or if in fact they're listening, they're watching, they now know the symptoms, they see these symptoms, maybe drooling, can't talk, the left arm aching, not being able to balance well. What if you, again, maybe this gets back to what Dr. Silverman was talking about, what if you then consume 2, 3, 4, 5 aspirins while you were calling 911?
I'm okay with that. And
But
the reason
can't that be a blood thinner and come
Well-
back to the problem that you were talking about, Dr. Silverman, and that is increasing in the brain,
But
that bleeding.
you've given us a very specific scenario of arm pain and
Right,
chest
okay.
pain. And if you believe you're having a heart attack, then it is okay to take some aspirin. And we would actually recommend that. In general, an aspirin a day is not a bad idea if you aren't sensitive to it or you don't have bleeding problems, because we know that people that take an aspirin a day actually lower their overall risk of stroke and heart attack over time.
Do you want to follow up, Dr. Silverman?
I would say that the idea of taking an aspirin a day is something that we routinely do in individuals who have many of the potential risk factors for stroke, those being hypertension, those being diabetes, those being smokers, those being patients with high cholesterol or high triglycerides. But just as Dr. Fessler has said, just aging itself is a risk factor to stroke. And as we get older, there's a higher risk for having stroke. So aspirin, or as an antiplatelet agent, is not something that I would not advise. And in the face of a stroke, I suppose I would not have a problem with a patient taking an aspirin a day, or an aspirin at the onset of the symptoms. I think the most important message that you can take from that thought is just because you take that aspirin doesn't mean that you shouldn't go on to seek help. Some people, I think, have a tendency, well, I'm going to take this aspirin and see if these symptoms go away. And that's the mistake that we all make.
What about taking 5, not 1, 5?
I think you're not doing yourself any great favor by just loading up and trying to treat the aspirin. I think you do a whole lot better getting to an institution where you could be evaluated.
Another email coming in from Robert, 64 years of age. There's an interesting question, too, that we'll get to, because you talked earlier, Dr. Fessler, about the older you get, the more likely you are to suffer a stroke.
Absolutely.
Male versus female, by the way. More men,
Both.
more women?
No, both. Men have more strokes in middle age, but as we go on, women begin to have
After
a higher
menopause,
occurrence.
same thing for a heart attack, for example. Men and women are pretty much equal after, age 50, something like that?
Even a little higher than that.
Yeah.
I think for stroke, late 60s to 70s when things finally begin to even out between men and women.
All right, so 64 years of age, Robert, and smoked for many years, now has atrial fibrillation and has had an increase in blood pressure in the last few months. Don't know what his blood pressure is, doesn't say here, but in the last couple of weeks had what appeared to be a couple of TIAs. And the TIA, again, is the transient ischemic attack.
Correct.
All right. So they had one of those TIs. What should he be doing? And are any programs to deal with this issue? Has no insurance, by the way. Dr. Silverman, I'll
Give
hand
me
that
the hard
off.
one?
Yeah, right.
All right. Well,
Dr. Fessler will chip
no
in as
insurance
well.
is really no problem. In reality, not just within the St. John Providence system, but I'm sure throughout the state of Michigan and locally here in southeastern Michigan, there are many programs. We have something called Doctors Who Care, and we all provide our care within those programs at no cost. So the fact of the matter is that while it's great to have insurance, the reality of the world as we live in it today, there are financial hardships, and we want to be there for individuals who have insurance and don't have insurance. So for us, it's Doctors Who Care. But the fact of the matter is that people who have had a stroke and who are having TIAs should look at those TIAs as being warnings as to an oncoming stroke. There was a study done in an emergency group just after the year 2000 looking at people who came to the emergency room with a TIA. And it was a group, and they had found that individuals who had a TIA were at higher risks for having a stroke within the next days and weeks and months as going on to having a major stroke. So we don't look at a TIA as being a benign event. We look at a TIA as being a warning of a more massive stroke coming. And a TIA is our warning and your warning to get some definitive evaluation to make sure that the treatment that you're receiving is optimal to protect you from going on to having that major stroke. So for Robert, I would say that if indeed you're having TIAs, this is your moment of opportunity to step into the medical community to do something to protect yourself from having a massive stroke.
Stroke is what we are discussing on this Tuesday afternoon. Your questions, emails at WXYZ.com, and your direct phone calls too, 248-356-0077 to our doctors in the studio, Dr. Richard Fessler, Dr. Bruce Silverman. They both specialize in strokes. And Glenn, you're on the line. Can you hear us okay?
Yes, I can.
What was your question for our doctors this afternoon?
Well, I hope I get this in words that you guys can understand. About 6 years ago, I suffered a stroke, and it was a type of stroke where the artery of one of the arteries of the back of my neck clotted over, and I have a problem to this day about dexterity. And I inquired at the time of the stroke if I was as good or bad as I was going to get at that time, and I was told that I won't get any better than I currently am. But now my question is, am I going to get worse? Because almost daily I feel like I'm getting worse.
What would suggest to you you're getting worse?
Well, each day I lose more and more dexterity. I'm starting to fall. I'm starting to shuttle with my feet when I walk, that type of thing.
What do you think, Dr. Fessler?
Well, Glenn, I think
Obviously, you can only do so much over the phone.
absolutely,
Right.
but one of the questions I would pose, you had your stroke 6 years ago, and I would hazard a guess that perhaps after that stroke you got better for a period of time. And
I think you're right.
And I think that, the real question is, have you had regular contact with your primary care doctor? And have you had ongoing exercise programs and physical therapy? Because some of the things that you're mentioning in your phone call may actually be new conditions. And so I would strongly encourage you to circle back with your physician and kind of take a fresh look at things.
A heart doctor or a family physician?
I think I would start with my family doctor.
Okay, I asked him probably a couple of years ago now about that question about getting worse or getting better, and his response was, I'm as good as I'm going to get, and I kind of let it drop until lately when I'm starting to feel worse.
And, and I certainly don't want to disagree with you, but I think we're talking apples and oranges. You've asked a question in the past, but now you've changed and it's the future. And so what you're telling me is that you had your stroke, you got better, and then a few years ago you started to have more trouble. And I'm suggesting that perhaps you need to circle back with your doctors and say, hey, maybe I didn't get better after a few years, but now I'm having these problems, and these are new problems. Could we take a look at these? Because not all of these new problems may be due to your stroke.
Oh, I see.
All right, Glenn, thanks for calling, and good luck. We appreciate it.
Thank you.
You're welcome. And those of you who have questions after we run out of time, don't forget St. John Providence's number, toll-free, 866-501-3627. That's toll-free, 866-501-3627. Doctors Fessler and Silverman in our studio this afternoon. We talked, too, about who is at risk for a stroke. After someone has suffered a stroke, Dr. Silverman, and they had been smokers, or they had been overweight, or they had high blood pressure, Do you find them realizing that they have to change their lifestyle and stop smoking and eat more healthy and get the exercise they need? Or do they fall into the same pattern that may very well have led to them having this stroke?
You know, unfortunately, human nature is very hard to change.
But this is your life.
This is your life. And for me, at least, it's really important to try to get that message out to the community, not only to protect them from having a stroke, but also, once they've had a stroke, to try to rally the troops, so to speak, to keep that person active and engaged in their own general health, and the family active and engaged in their own general health. I know Dr. Fessler and myself, we've reached out to the community in something called Dinner with a Doc. And through the St. John healthcare system, we've had very large community meetings where maybe 200 or 300 people, maybe 150 to 200 people will come to our community centers to hear about and remain motivated towards the management of stroke. We have a very active parish nurse process that goes out to many of the different community centers and churches, that reaches out to individuals and families to keep people motivated against falling back into their patterns that got them into this bind, managing their blood pressure, managing their cholesterol, managing smoking, diet, exercise, etc. All those risk factors are extremely important to the success of not going on to having a stroke or to protect you against another stroke from occurring. But I would say, unfortunately, unless you keep the family and the patient engaged, people tend to fall back into their patterns.
And Dr. Fessler, when someone goes to their primary care physician, what can be discussed, what can be looked at, what can be tested to determine, oh, you know what, you are getting to be or are a stroke patient, that you are in danger of having a stroke, like some other things that we might go to our doctors about, and they'll find, well, maybe it's high blood pressure, and then they immediately conclude that, oh, your blood pressure is high, so you are a stroke candidate.
Well, there are a few simple things. Actually, and blood pressure is one of them. So folks who have high blood pressure are at increased risk. In order to diminish that risk, we like to get folks on medication so that we can bring it down to normal. The other thing is diabetes. Do you have diabetes? Diabetes and high blood pressure work together to increase your risk. And controlling your diabetes, controlling your blood pressure, both would lower your risk. Certainly more than someone, you're still at risk more than someone who doesn't have high blood pressure, diabetes. But if they're well controlled, you're at less risk than those folks who have both things that aren't. Add smoking on, high cholesterol, high triglycerides, and a sedentary lifestyle. All of these things sort of add up as not only what we call independent risk factors, but they can also add together to become even worse, right? So your primary care physician looks at that whole scope of risk factors, which are very common in our North American population, and they're well informed and very capable of helping folks begin to modify their lives.
And Dr. Silverman and Dr. Fessler talking about diabetes, where the body, A, is not either making enough insulin or the body isn't using the insulin that the body is making. How will that lead then to the possibility of a stroke?
Well, specifically in the case of diabetes, diabetic vascular disease is a form of atherosclerosis or hardening of the arteries. So individuals that are diabetic are at increased risk of developing blockages in their blood vessels. And in doing so, as these blood vessels become more blocked, or as they develop the formation of a plaque, which is an irregularity along the lining of a blood vessel, and that plaque breaks off or the blood vessel becomes occluded, then that can lead to a stroke. But I want to share with you just a couple of thoughts. You've made some really interesting comments here, Warren. You said that there's nearly 750 or 800,000 strokes in the United States on a yearly basis.
Every year, yeah.
But what you didn't mention is that every 45 seconds, somebody in the United States has either a TIA or stroke. Every 45 seconds, someone in our country is sustaining a cerebral vascular event. And while that's great for business, it's really crummy for patients. And so the idea of risk management when it comes to taking care of and protecting folks from having a stroke is a huge, huge issue for us. And so I shared a couple things. I'll recant one or two.
Sure.
But stopping smoking can lower your relative risk at 1 year by 50%, and at the end of 5 years, it can take your relative risk of having a stroke down to baseline.
And add decades to your life.
And add decades to your life. Patients who suffer from hypertension and diabetes, if you have your blood pressure and your blood sugar managed properly, you can lower your relative risk of having a stroke by about 44%.
So if you're over 140 over 90, then you're getting to be at a high risk in somehow, some way, whether
You
through
are.
medication or, I don't know, maybe exercise, maybe eating green leafy vegetables. Somehow, some way, you got to get that high blood pressure down, Dr. Fessler.
Absolutely.
So when we talk about risk factors, that's what it's all about. It's about managing your risk factors. When I give my talk to these dinners with a doc,
Right.
I tell them there's only so much that we can do. Managing stroke is really in your hands. It's in your primary care doctor's hands. It's managing your medical condition.
All right, let's get some more incoming emails here. And you're at WXYZ.com, so you simply get online and you give us, let's get, if we could roll back, because I think we missed one of the emailers here before the Sherry email. Her husband, Sherry, has suffered a stroke back in March of this year. Called 911, we talked about that to be sure. When he woke up with slurred speech, that was one of the symptoms, difficult moving on his right side. At the emergency room, there was a CAT scan done, and they said it showed nothing. However, with all his symptoms, she was truly disappointed that the medications to dissolve the stroke were not administered. As the day went on, there was, from what she's saying here, there was an MRI done, and it was evidence that he indeed suffered a bleed on one side and a blood clot on the other side of his brain. What could have been done to prevent this from happening? I mean, you go into an emergency room, you're not a doctor, you just are trusting the doctors to do what they're supposed to do. How do you respond to Sherry here, Dr. Silverman?
Well, unfortunately, this is a common story.
Really?
It's very common. And part of it is...
You say, do an MRI right now. I want to know what's going on with my husband.
Well, this is a very complicated story. And it's filled with lots of very fruitful information for your listeners and for your watchers, because it tells a story of somebody who had a stroke. On the other end of the story is the medical management of this person with a stroke. And so if we go back to what we consider to be our Hippocratic Oath, we try not to do anything that would be harmful to the patient. So one of the things that we really need to look at is the story in its totality. And the reality is that when you have a wake-up stroke, it kind of changes the rules as to when the stroke occurred. Because the reality is we do not have a defined moment of when that stroke occurred, when you wake up with a stroke.
Could have been hours, could have been days developing.
Well, we don't know. We have to go back to when the patient was last known to be normal. So if you wake up at 8 o'clock in the morning and you have slurred speech and right-sided weakness,
Right.
we really don't know whether it started at 2 o'clock in the morning or midnight. We can only go back to the last moment that somebody saw you and you were normal. So if you went to bed at 10 o'clock at night, but you woke up at 8 o'clock in the morning, in order to be able to define when the last time you were known to be normal, you really have to say the clock started at 10 o'clock in the evening, not at 8 o'clock in the morning when you woke up. So that's one of the challenges that we as a team have looked at, because the second issue that she said was the CAT scan was normal at the very beginning.
Right.
And the reality of that situation is that we want to see a normal CAT scan, Because if we see a CAT scan that shows a large stroke, it really limits what we can provide the patient.
But the follow-up MRI showed that there was something there, and the CAT scan didn't. So is it the normal procedure to say, okay, the CAT scan didn't show anything, and then not to do an MRI?
Well, the criteria for management of most patients in the face of the use of a blood clotting agent like IV-TPA, which is what I believe Sherry is alluding to, we really don't need an MRI to make that decision. We need a CAT scan. And the CAT scan, if it doesn't show a bleeding in the brain and it doesn't show a large stroke, is all that we really need to make the first decision of whether or not the patient can get the IV blood clotting agent. The issue, as I see it from the storyline that's been given, is that the last known to be normal time most likely exceeded the 3 or 4.5 hour window that we are able to provide the drug for. And therefore, the patient was not a candidate for the blood thinning agents because they were beyond the window of opportunity for care.
All right, they've had the symptoms, they're called 911, they're at the emergency room, and Dr. Richard Fessler, as someone who specializes in interventional and surgical treatment for stroke, what do you do?
Perfect segue.
I listened to Dr. Silverman. No, we take care of a very small, specialized group of patients. And sometimes this patient that we're just talking about would be someone who would fall into our hands. Because when patients aren't candidates for that medication to be given by IV, we sometimes can still go in and take out that blood clot. And
How do you go in and take out the blood clot?
we do that through a very tiny nick in the leg. We enter an artery in the leg, and we can travel all the way up into the brain with very small catheters, and we can snare that blood clot and pull it out. And the way we decide is we do a special type of a CAT scan that we call a CT perfusion study. That study tells us whether the brain can be saved or not. So it lets us know, has an irreversible stroke occurred, or is the brain in the process of losing its life, but we could still reverse that ischemia or that brain death. And so if we have that window of opportunity, we mobilize an entire team of individuals and we head back and we try to do that for that patient.
Let's try to get to a couple more quick ones here before we run out of time. Pat's wondering, can a seizure, Dr. Silverman, can a seizure be confused with a stroke? In either case, can muscle stiffness afterward be a result? And this is from a 63-year-old male wondering about that.
You know, that's one of the relative concerns when a person comes in the door with stroke-like symptoms, is whether or not they had a seizure. A seizure is a unusual or abnormal electrical discharge which occurs within the brain, over the surface of the brain. And if you have this irritable focus in the brain that is in a region related to motor strength or speech, regardless of the particular region, if that area becomes irritated, those neurons will be stunned and the patient will lose that particular function. So if it happens to be in the motor strip, you'll have weakness. If it happens to be in the speech area, then you might lose speech. And so it's very important for individuals who are with a patient who's having a stroke to observe the patient. Because if they observe a seizure, I was caring for a woman just yesterday who had a seizure, came in with a right-sided weakness. Within relatively short order, as those neurons begin to repolarize themselves back to a normal neuronal state, that function will return. And we call that a TODS, post-ictal paralysis. And so seizure can mimic a cerebral ischemic event or stroke. And so you need to be mindful of patients who have seizures, because if you believe strongly that this is a seizure, then you may not give them a blood thinning agent. Oftentimes it's difficult to separate the two out.
Final email coming in for both of you, Dr. Fessler. this email says they had heard that you should write the time of the first symptom on the patient's hand to give details to a doctor. Have you ever seen that in your surgical practice?
I have not.
Is that a good idea?
I would ask that that person with that information accompany that patient to the emergency room, actually.
What did you make of that, Dr. Silverman? Heard that you should write the time of the first symptom on the patient's hand to give details to the doctors. Maybe that's so you don't forget or something like that.
I would agree. It would be very difficult because if you never turn the patient's hand over, you may never find that. I think a verbal transmission of information is oftentimes the most successful to get to the medical practitioners. And I believe that transmitting the information to the EMS people would probably be the most logical way, for me at least, to have accurate information.
And we'll have to leave it there. May is National Stroke Month. Keep that in mind. Our doctors, Richard Fessler and Bruce Silverman, doing their best in just the last hour to make sure you're aware of that. If you have more questions, the toll-free number to call is 866-501 and then
3627.
What is it?
I think it's 3627.
866-501-32.
3627.
Do I have it yet?
3627.
3627. And maybe this is a senior moment. Oh, you'll work on that. I'm Warren Pierce, thanking you for tuning in, and stay well and healthy.